So we'll go ahead and get started. It's 10 after. We are waiting for participants to join. So this webinar, we have the honor of hosting Esther Lucero, and she will be presenting on urban Indian policy. We're going to start with our land acknowledgement. We begin by acknowledging with humility that the land where we are today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people since time immemorial. So just a little bit of technicalities. I will be the host of the meeting. Tiffany will be the co-host and also the technical support. So if you do have questions regarding anything that has to do with any technicalities or troubleshooting, you can reach out to Tiffany Edelin, and she is on the line as well. And we were originally gonna put our tribal learning off, but we recognize now more than ever the health inequities among different populations are glaring. We acknowledge that most of your time is dedicated to COVID-19 mitigation right now. However, we must keep equity for all as our focus throughout. As the Sound ACH's commitment to providing our partners with education around health equity and tribal learning, we are continuing our journey through these times of uncertainty. And with that being said, I am going to introduce our CEO, Liz Baxter, who has a few words to share on equity learning.
Great, thank you so much, Tempest. And you probably actually said most of what I would have said. Probably about 2 years ago, the Sound ACH made a commitment along with our team and our board of directors to go on a journey of tribal and equity learning. And we have had multiple large meetings and many smaller meetings to talk about this. And I think our board meeting from a couple of weeks ago was perhaps one of the signs that this commitment that we're kind of starting to walk our talk, I guess, in that, as we're all doing Zoom meetings, it's easy to think about putting off tough conversations until some moment when we can go back to being in person in a room. And having our board leadership say, no, we're not putting these conversations off, and they actually dedicated 90 minutes of their last board meeting to talk about issues around race and privilege and equity was pretty amazing for us. And so this notion of COVID-19 and the coronavirus and what it's doing to our communities really makes the issues around equity more compelling for us to keep those top of mind. So, just really excited that Tempest, you were able to pull this session together, and so grateful, Esther, to you being willing to spend time with us. So thank you very much.
Thank you, Liz. And then some virtual learning tips before we get started. So just find a quiet place, shut the door, and when you aren't talking, if you can mute yourself, use the chat box to raise questions or comments. And then use a webcam if possible. Just seeing one another builds trust and engagement. Do not put your call on hold. This may result in the rest of us hearing your hold music. Be comfortable with silence and pauses to avoid speaking over someone else. Avoid distractions such as emails and messaging. And then lastly, take care of yourself as needed. Use the restroom, drink water, and stand or stretch. With that being said, I'm going to introduce Esther Lucero. So Esther Lucero is Dinè and Latina in a third-generation urban Indian from Colorado Springs, Colorado. Esther received a Master of Public Health Policy and a BA in Native American Studies from Mills College. While living in California, While living in California, Esther served as the Director of Policy and Programs at the Native American Health Center, where she gained a strong understanding of the importance of cultural and evidence-based practice while working to prevent substance abuse. Soon after, she became the Director of Programs and Strategic Development for the California Consortium for Urban Indian Health and Behavioral Health Advocacy for 10 urban Indian health programs throughout California. In addition to her work to Urban Indian Organization, Esther has taught classes at San Francisco State University in American Indian Studies and San Francisco Art Institute in Urban Studies. She served on the board of directors for the Intertribal Friendship House and the Alliance for Girls. In 2015, Esther was recruited by Seattle Indian Health Board for the position of CEO. The organization's dedications to its community and commitment to workforce development and epidemiology, along with its national presence in the policy forum, attracted Esther to lead the organization into a new era. In her first 3 years of the organization, she increased the operating budget by $11 million and completed a reorganization. She has built a team-based environment and established an executive team to lead the charge toward the implementation of the first of its kind, Indigenous knowledge-informed system of care. In recent years, the organization has increased its prominence locally and nationally. Esther currently serves as the co-chair for Healthier Here's governing board and serves on the governor's behavioral task force. She is a delegate to the American Indian Health Commission and serves on the Native Communities Committee under the leadership of City Council member Deborah Juarez. Esther was recently appointed to the City of Seattle's LGBTQ Commission and Community Police Commission by Mayor Jenny Durkin. Esther's passion and advocacy for Native health, transformative approaches to Indigenous research and evaluation, and federal Indian law and policy has made a leader in the health in Seattle and nationally. And Esther, thank you for joining us. And I'll turn the mic over to you.
So you could help us undo this.
Okay. I'm going to share my screen. So let me see here. I think Tempest, you have to stop sharing yours. Let me see. Huh. Oh, here we go. Okay, can everybody see that? Okay, wonderful. So Yat e bene, everybody. My name is Esther Lucero, and you know, it's really humbling oftentimes to hear that bio read. Obviously, my team wrote it, and I think that it lacks a lot of humility, so I apologize for that just in advance. I will say that it is an absolute pleasure to be a guest on this land, you know, to be here in Seattle in the midst of the people of the Salish Seas. It's really an honor to do that. And you all are up in the North Sound, so you don't actually have any urban Indian health programs there. However, I think that there are a lot of ways that our history is intertwined, and actually, quite frankly, our existence as an urban Indian health program is completely dependent on tribal sovereignty. And so I think that you'll find some of those things very useful in this conversation today. What I want to share with you today is largely grounded in the work of the Seattle Indian Health Board, specifically our policy work. Yeah, I will say that there's a bit of that bio that's out of date, and that is the fact that I actually ended my term as co-chair for the King County ACH Healthier Here in April. So I'm no longer doing that. However, I will say that it was a complete honor to be able to do that. And I think that it's one of the ways that we have been able to lead the charge in working with our tribal partners and our urban Indian health partners, really specifically in the allocation of resources and dollars, and being more culturally aware and implementing an equity model that I think that is a standout from anything that's happening in the state right now. So those are things that I would just like to share with you as an introduction. And with that, I'll just jump into my presentation. So who in the world are urban Indians? Let me just start with the data point, okay? As you heard in my bio, I'm actually third generation in my family to live off of our reservation. And so I grew up completely in an urban environment. And so I feel like I have a lot of the same lived experiences that our relatives have. Oh, let me just clarify this. We call our patients our relatives here at the Seattle Indian Health Board. So you'll hear me refer to that. And the reason we do that is because we serve folks from all over. You know, we serve folks from all over the US and even sometimes other Indigenous populations outside of the US. So it is very important that you understand that we serve, I think in our last census, we had over 250 federally recognized tribes represented in our patient population. So that gives you some perspective. Now, keep in mind that every single tribal community has its own distinct culture, own distinct government systems, and own distinct way of being. So it's a very interesting nuance to actually lead an urban Indian health organization. The other thing that's not common knowledge, I suppose, although it should be, is the fact that 71% of all American Indians and Alaska Natives live in urban environments. And you'll begin to understand why that is so in just a moment. Okay, so the Seattle Indian Health Board, I arrived here almost 5 years ago now. And at that time, our organization had been in existence for 45 years, right? And we'd already had a history and legacy of doing really significant policy work. So I felt very privileged coming to an environment like this where not only did we have the health side of things, because we operate as a federally qualified health center in addition to being recognized as an urban Indian health program, but we also had we host the Urban Indian Health Institute, which is one of 12 tribal epidemiology centers in the nation, and the only one that actually has a national scope because we serve all of the urban programs across the country, and right now there are 41 of them. So that's a very unique aspect of our organization. Additionally, we operate our outpatient clinic, but also had 65-bed residential treatment program. So it's a very interesting organization from that perspective. So what does a person do? I mean, I was a first-time CEO. I've never been in this position. I knew policy work really well, and I definitely felt like I had at least some kindling leadership skills, at least according to my mentors and my teachers. And I show up in this organization that is already, has really strong reputation. And so it also came at a time where healthcare was changing, right? The ACHs didn't exist. Why? Because they were actually an extension of Obamacare to really move us towards full integration. So I walked into an organization at a time where the whole healthcare environment was changing. So I have a choice as a new leader, and that is I could try to keep things copacetic, right? Just do things as they always had been done. We could go out of business because, quite frankly, with the new third-party billing model, if we didn't implement that well, it would really impact our revenues. Or we could just really reinvent ourselves. And so we actually chose the third. So we developed what we're calling our Indigenous Knowledge-Informed Systems of Care. And it's the first integrated model of its kind that is actually centered on traditional Indian medicine. So not only are we integrating behavioral health and primary care, but we have a traditional Indian medicine apprentice as part of every single panel team. We've also incorporated dental into those panel teams. Oftentimes you hear in the healthcare environment that dental is thought of as kind of like a tertiary activity, but the truth is everything that occurs in dental can be prevented. And dental is a very good environment to identify, potential illnesses. So it's a really key tool in preventative medicine, right? So in addition to that, we recognize that substance use disorders are really challenging. So we wanted to make sure that we had access to our substance use disorder professionals within those panel teams. Domestic violence, we know runs rampant. I'm thinking about COVID today and how we're actually seeing increases in the number of domestic violence cases. So we wanted to make sure that we had both health and human services all incorporated into these panel teams. Right? So we're talking nutrition, dental, traditional Indian medicine, primary care, behavioral health, and SUD, domestic violence, homeless case management. We have if you're American Indian, Alaska Native in the city of Seattle, you're 10 times more likely to be homeless than any other ethnicity, right? So we know that it's not always about that patient-provider relationship, that our people, in order for us to be fully well, we have to have access to these other support services. And sometimes that's the way in. To really help people become healthy. So we designed that from a healthcare delivery perspective. And then we also wanted to build upon our strengths. And some of our strengths are the fact that we were the very first urban Indian health program to provide congressional testimony. And that happened by Luana Reyes, who was the second executive director for the Seattle Indian Health Board. That's something that we continue to do today. In fact, we've actually expanded our reach there. And not only do we visit the House Appropriations Committee every year to provide congressional testimony as a CEO, but also our Chief Research Officer, Abigail Echohawk, also participates in that. And we are beginning to branch out into the labor age committees as well, because we recognize that that's where the research and community health center funding lives. So that's a very important piece. We also expanded our reach. So we used to do largely federal advocacy. And we recognize with the changing environment for healthcare that states then began to gain more authority over healthcare. And what the states did is then distribute those resources through local environments. In some cases, like in the state of California, that was the counties. But in our state of Washington, it evolved into the accountable communities of health, right? And so that's where the 1115 waiver dollars came through, the innovations funds, that's what they're called, and then established those. So now here we have a federal responsibility to American Indian Alaska Native Health that's being transferred to a community governing board. So it made it very interesting to expand our policy work from federal to state and now local environments. So that was one of our pillars. The other strength we have is the fact that we have the Urban Indian Health Institute. And so we knew that we did a lot of surveillance, epidemiology, and data through that division. We needed to expand it to research so that we could begin to build data by Native people for Native people. And I think that the true partnership between those two divisions within our organization have really become a catalyst for the success that we've had in the policy environment. The other thing that we do really well is we do workforce development. We were the very first urban Indian health program to establish a family medicine residency program. And I'm really proud to say that 5 of our 6 residents are Native. And so we've maintained a true commitment to building our next Native workforce. More recently, we actually established a MSW practicum program. We have a traditional Indian medicine apprentice program. We train SUD professionals, and we also are we have dental students that come through. We have learners in pharmacy, and so it's something that we're truly committed to. So when you look at our theory of change here, that's what you're seeing. You're seeing our pillars that are really interconnected because we're all related, right? And so for folks who are not familiar with the medicine wheel concept, largely this comes from more dominantly from the Plains tribes, but each of the colors and directions mean something to us. So if you think about the colors as representing cultural communities, it's a way that we are saying that we're all connected regardless of our race and ethnicity. And if you look at the blue that kind of surrounds those colors, what we learned from our Alaska Native tribal community partners is the fact that they don't even understand the medicine wheel. That means nothing to them. And so they said that the way they communicate and the way they stay intertwined and connected is through their waterways. And so when we designed this, we designed it with that in perspective. And as you see, traditional Indian medicine is at the heart of everything we do. And that means that every single one of those categories of change are grounded in traditional Indian medicine. And that cultural transformation in and of itself has been massive. So this is an example of the healthcare approach that I just described. So oftentimes we hear trauma-informed environments, right? Take a trauma-informed approach. And that is true. I would say that it's very important to recognize that we all have our own experiences of trauma. it's equally as important to recognize that we all have our experiences of strength. And I think particularly in American Indian, Alaska Native communities where cultural genocide is truly the goal and the intention is to eliminate us as people. And the fact that I'm sitting here before you today as a Native woman leading an organization like this and transforming our healthcare system to really meet the cultural needs of our people first tells you how resilient we are. And so we recognize that not only was it important to talk about trauma, but it was always also important to talk about resilience. And so our Indigenous knowledge-informed systems of care is all grounded in a strengths-based approach to care and to healing. I explained a little bit more about the holistic approach we take to care, that we treat all disciplines in parity. You know, we hear things like, I think it was 1995 Parity Act, where you're supposed to treat behavioral health and primary care in parity. And we know that that's not true, right? We know that reimbursements are different. We know that the way that they're trying to integrate behavioral health into primary care suggests that behavioral health is just a subsidiary of the broader medical environment. And that's just not okay, right? Because our medical environment was really designed as sick care. Our reimbursement models were designed so that you get reimbursed by how sick somebody was, not how well. So I would say that here in our organization, we treat all disciplines in parity, and then maintaining a commitment to being culturally attuned. Okay, so let's get back to policy, right? Because I want to focus on policy and the research parts of what we do here. Now, I'm going to tell you first that policy work is never done alone. And these are our internal champions. So Aaron Spark is Chupik from Western Alaska. He's also Jewish. And if he were here, he would tell this joke that's funny every single time. That makes him a Jupik, he says. And he says that he's one of 10 in the nation who are Jupiks. And he's very proud of that. He also talks very quickly. And you'll find that in the policy world that our policy folks, they talk in a way that's, it's really quite shocking. And mostly acronyms too. It's even worse than healthcare environment. And then we have Abigail Ekohak, who is our Chief Research Officer and has really championed pivotal policy work regarding missing and murdered Indigenous women and girls. And, you know, she's truly she's quite brilliant when it comes to research and evaluation. And she coined the term decolonizing data, because that's how we do our work here. So these two, I get to work with every single day. And to me, I learn from them every day. And I happen to be public policy. That's my background, my academic background. And quite frankly, I think that I've been obsessed with policy since I was 5. Didn't know it. I took a lot of different paths to get here. But I think the three of us together, we have a really, we recognize how important the work is, but we also just love it. So. We also understand that we're not an Indian expert and we're not an expert Indian, right? I think especially organizations that, that don't have a lot of access to tribal communities or haven't been in tribal environments to actually experience our culture and way of being, or haven't interacted with a lot of Native folks. They're always looking for that one Indian expert, you know? And I was told by an old mentor, like, you're either gonna get asked to pray or you're gonna get asked to, you know, to speak for everybody. And I want to be very clear that we don't speak for everybody. We speak for the work that we do. I can speak about my experience as an urban Dinè woman, and I can speak about our experiences of our community, because we put systems in place so that I listen. And I'm really responsible for carrying their voices forward. So let's be very, very clear. Now, you guys, the ACHs have done a very good job in hiring the tribal liaisons, right? But I want you to remember this slide when you think about them, because they're doing the very best they can to connect you to a variety of diverse tribal voices, right? And just Native voices generally. But I have to tell you, man, we have a rock star crew. I think about Tempest and I think about Abriel, Johnny. I mean, these folks, they're gonna be running the show someday. So let's be clear about that. All right, so let's get started in a little bit of historical precedents. Like, how is it that urban Indians came to be? How is it that we actually have a separate avenue for advocacy? Like, why does that exist? So I'm going to take you on a little history lesson, and just bear with me, okay? Because this can get a little bit wonky, but it can also be history lesson that perhaps not many of us actually received in school. So let's start off with the Doctrine of Discovery. Doctrine of Discovery is the document that was written by the Pope that gave early European colonizers this perspective that they had a right to conquer land, that it was vacant and they had a God-given right to conquer land. So when they early European colonizers arrived to the Americas, they came with that perspective. Not only that, but largely they brought thieves and they brought criminals with them, the folks who could actually sustain this journey, and they were all men. That's the other thing, okay? So let's think about that perspective merging with some of our tribal communities who were matriarchal, right? Where women held most revered positions, or two-spirit folks held the most revered positions, where our government structures were more communal based and kind of collective voice, right? So just imagine those two philosophies meeting one another. When they realized that, in fact, our lands were occupied and that there were millions of us here, they recognized us as nations, right? And so that began the treaty making era. So the only folks who are able to engage in making treaties are nations, right? Nation to nation. We have treaties with Canada, we have treaties with France. And so our tribal communities, our tribes, were able to engage in those treaties. That means they are defined as sovereign nations, okay? We'll get into that a little bit more, but I want you to understand that they were recognized as a government-to-government entity. When they understood that, in fact, this land held an abundance of resources, yet it was occupied, they started to move our folks west, right? And so that's where we see kind of this influx of all of these different tribes placed in Oklahoma. I use Oklahoma as an example because they thought it was the most desolate land. And so they thought there were no resources there. And quite frankly, they were trying to create a land-based example of an Indian prison. And they also disregarded the fact that we had multiple tribal communities with individual perspectives and cultural ways of being. Some didn't all get along, you know, not all of them got along, and they forced them to live in a common area. That happened until they recognized that there was oil in Oklahoma. So let's keep that in perspective. Once resources came into play, then the land became more valuable again. Reservation era. So at that time, when we moved a whole bunch of Native folks west and we placed them on this land that was unfamiliar, so it was away from their traditional foods, away from the traditional medicines, away from their ceremonial grounds, you know, we started to deconstruct our ways of being and knowing, and it impacted us negatively. The reservations were created because then at that time, the federal government recognized that they had to do something because we were not doing well, right? And so of course, in this paternalistic kind of patriarchal way, they took responsibility for us through reservations. Allotment and assimilation came shortly after. So they said, well, if you can't exist now because you're moved west and you're away from your cultural way of being, then now you need to assimilate with us. And so that's where the allotment era came in. And again, I'll use Oklahoma as an example. So if you imagine Oklahoma as a square, and I know it's not because it has that little arm up at the top, but if you imagine it as a square, imagine taking 10% of that land, setting that aside as Indian country, and then literally checkerboarding the rest of that land. And within that checkerboard, you put a white family next to a Native family. And you created this rule that said, hey, you Native family, if you can learn to cultivate the land in the way that these white settlers do, and you can prove to us that you can do that for 25 years, then we will gift this portion of land to the head of household in your family. And of course, they define that head of household as the oldest man in the family. And again, for many of us were maternal societies, matrilineal societies. So for us, like my grandma would be really upset if you thought about my grandpa as head of household. That just doesn't work, right? Additionally, we already had our own ways of cultivating land. And so in that time period, we actually lost 90% of our land. Okay. Recognizing that these systems were not working, we began to do assessments. So that's where Indian Reorganization came in, where they said, oh my goodness, all of these things we put into place are not working, we're underfunded. And so you start to see a little bit of a transformation there, where they said, we've got to do something differently. So next stage was, well, we're going to further advance our assimilation goals. And this is where urban Indians really live. So termination and removal. So this is urban Indian, it's called the Urban Indian Relocation Act of the 1950s, and also the Termination Act, which was piloted in California also in the 1950s, both with one goal. So essentially what they did for urban relocation is they said, hey, you Native people, you have access, you can become a doctor or a lawyer, you can have access to education. And you have to remember, resources were scarce, right? We had rations that were being withheld by the Department of the Interior. We had people who were hungry, who didn't have access to work, those types of things in our reservation systems. And so this was very appealing, this idea that you could go make money or you could go and get an education. So they handed folks one-way bus tickets to move to 12 relocation sites, right? These 12, Seattle was one of those relocation sites. Other relocation sites you see are the Oakland area, San Francisco Bay Area, that's another relocation site. And so they moved all of these Native folks from different tribal communities to cities. Only when they arrived, those promises of education, of getting a liaison, of getting jobs were actually not kept. So you start to see this influx of Native folks into cities. And so what do? Well, we're resilient people. So we came together and we began to share with one another, right? We are also activists. We learned how to be activists very quickly. And so we were able to rise up together. So the other piece was the Termination Act. And a lot of people don't know about this. So the Termination Act was interesting. It was designed in a different fashion. So what they said to tribal communities, they said, hey, tribes, you can have title to your land. Here it is. We will give it to you. Only in order to accept this, you are no longer considered federally recognized by the federal government, right? You can have complete autonomy over this land. And so some tribes said, yeah, we want to have complete autonomy. And what happened was then states were allowed to collect back taxes on those lands. So if you think, I don't know if folks are familiar with California, but you see a lot of terminated tribes. So there's 54 tribes in California trying to reestablish federal recognition because they were terminated. But you also see other tribes who have who are federally recognized but only have a small plot of land. They call them rancherias, right? We have a joke in Indian country where there's like enough room for a casino and some hut homes, and that's all you have for a plot of land. And that was because in order to pay those state back taxes, you actually sold your land, right? So that's how we ended up with those two time periods, both creating an influx of Native people into urban areas. So then you rise me. That's what an urban Indian is. We are tribal people living in urban environments. Okay, so it gets a little better, but you notice on this slide, there's only one slide that looks better, and that is, it's called self-determination without termination. So in 1975, the Indian Self-Determination Education Assistance Act was signed into law by President Nixon. And that was the first time that the federal government recognized that Indian people know what's best for other Indian people. And so we began to take control over our programs. So that is where we are, I believe, even till today. So this is just a slide that gives you an idea of the millions of folks who were impacted by these genocidal policies. So just gives you some perspective there. This is the foundation for federal Indian law. Marshall Trilogy. I like to share this because this really helps us understand sovereignty and how we got to this place of sovereignty. So the Marshall Trilogy was comprised of 3 different law cases. The first one, and I'm going to try to do this from memory, was Johnson v. McIntosh, actually. And in that court case, the finding was that Indians could not own land because they were deemed heathens and infidels. And so they only had the right to use and occupy land, right? So that was the first case of the Marshall Trilogy, began federal Indian law. Second case was the Cherokee Nation versus Georgia. In Cherokee Nation versus Georgia, the ruling was that because tribes are dependent on the federal government for commerce and protection, they were deemed domestic dependent nations. And so what that means is we're like a nation within a nation, right? That the federal government has an obligation to our tribal nations. And then the third case was Worcester v. Georgia. And that was a case, what the ruling in that case was that only Congress has plenary power over Indian nations, right? And that Congress is supposed to make decisions in the best interest of all Indian people. So that is the foundation for federal Indian law that we're working from still today, right? And the first case started in 1823. So gives you some perspective. It's important to note that Indians were not citizens until 1924, and in some communities didn't have the right to vote until 1978. So let's see, Morton v. Mancari is very important because it was the first time through federal Indian law that Indian nations were identified as not only an ethnic identity or racial identity, but also a political entity. And so my advice to everyone who's working with tribal communities, you need to remember that, right? You cannot lump us into these categories. Like we are not like Latino or Black community. We hold a political authority. And so you have to remember that's who you're dealing with. So when you're calling a tribal chair to your table, right, to your governing board, it's like calling the president and saying, I need you to come join our board, right? So that gives you a little bit of perspective. In the federal trust responsibility, you hear about that a lot. Like, what is the federal government accountable to? What are they responsible for? This was actually as a result of the cessation of land. So all that land I talked to you about that we lost, 90% of our land, was supposed to result in these commitments from the federal government. So we were to receive food, housing, education, healthcare, and the economic workforce, right? Those are the things that we have prepaid for through land. Where we exist as an urban and Indian health program is in that healthcare portion, right? So our tribes are sovereign nation and are sovereign nations, and we are an extension of that sovereignty through tribes. So we take care of our tribal people when they move to cities. So we talk about it as the ITU system of care. So the I stands for the Indian hospitals. You can think of it that way. We don't have any in the state of Washington. So it's IHS Direct, operated by IHS. And it says we have 4 facilities, but I'm not quite sure where those are. I was told that we didn't have any hospitals, but I don't know. Tempest, are you familiar with that? No. Okay. So I'll have to double check on that piece. Tribal 638s are actually the tribes that have taken ownership of their healthcare services, right? So they're their own healthcare authorities. And then urban Indian health programs are us. So we can also be 330, HRSA funded, but not all are. So that's really important. And we have 2 of them here. It's us and Native Project. So the ITU services began through the Indian Self-Determination Education Assistance Act, because that's where our Tribal 638s came through. The Indian Healthcare Improvement Act is now embedded in the Affordable Care Act. And what happened for us as urban Indian health programs within that act is 2 things. We actually, our Urban Indian Health Program line item was permanently reauthorized through the ACA. Additionally, our tribal epicenters, so our Urban Indian Health Institute, was authorized as a public health authority. So it's very important that we think about that. So when we hear things like, oh, they're going to be dismantling the ACA, or they want to remove the ACA, that's what it would mean for us as an Urban Indian Health Program, right? If our authority lives there, losing ACA is pretty significant. Social Security Act has a pretty significant impact related to 100% FMAP. I don't know how many folks are familiar with that, but obviously that's the match percentage that the federal government provides the states for serving really challenging communities, or communities that actually have high costs associated with them. For American Indians and Alaska Natives, the tribes have access to 100% FMAP, but urban Indian health programs do not. Okay, so that's very important. However, we have asked the state for a reinvestment in the overall ITU system of care, and I'll explain that in a little bit later. Tribes have the right to tribal consultation. So any administrative body that creates a policy or system change that impacts tribes, they have to consult with tribes. They have to provide notice, and they have to give a response within 30 days, right? They have to ask the tribes their perspective and opinions before making these changes. We as Urban Indian Health Programs have the right to an urban confer, but only through the Indian Health Service System. So anything related to healthcare, we have a right to be able to have a confer session, okay? So what are the impacts of the Affordable Care Act on the ITU? Well, because our Indian Health Service System has been grossly underfunded, and let me give you some perspective there. We spend about $3,000 per capita for American Indian, Alaska Native folks through the Indian Health Service System. It's about $5,000 for prisoners, and I think it's upward near $8,000 or $9,000 for the general Medicaid population. So that gives you an idea of how grossly underfunded our Indian Health Service System is. So the ACA attempted to supplement that underfunded system with Medicaid dollars. And so we were asked to implement these third-party billing systems that we never had to do in the past, right? So that happened in 2010. Then, because the resources started to go into state systems, I've already said this, that states gained more authority. We are very lucky in the state of Washington because we've actually adopted the Centennial Accord. So our state is very comfortable and familiar with working with tribal communities and recognizing sovereignty, right? And they've made a commitment to continue that. But that's not like that in every other state, right? In every other state, they're like rushing to understand what this means to work with tribes in this way, because states have no authority over tribal communities. And then I already talked about the permanent reauthorization and the public health authorities. All right, so understanding all of this history and background, and by building careful strategy from the local, state, and national levels, I want to give some perspective on our last year successes, policy successes. And so at the federal level, we had a $6 million increase for the Urban Indian Health Programs, which is the largest we've ever had. $1 million increase for tribal epicenters. That's the first time that has occurred, and that is a direct result of our advocacy with the Northwest Portland Indian Health Board. It was our area that actually put forward that recommendation, and it was passed. There's been urban Indian inclusion in key legislation. We've been working on that very, very hard. I think one of the one of the biggest things we're proud of, and this is working with the state, is we were able to get the Washington Indian Healthcare Improvement Act passed, and that is what I was talking about. We asked for a full reinvestment in the overall ITU system of care that was budget neutral, because it came from the 100% FMAP cost savings that the state received, and that allowed us to maintain our cultural integrity while implementing healthcare within the state of Washington, which is amazing. We've had several pieces of legislation addressing missing and murdered Indigenous women, both at the state level and at the federal level. We've had a CMS carve out so that our urban Indian health programs could actually work directly with our tribal partners and not have to go through a BHO to be able to get our folks into inpatient treatment or into services. That was a very significant move for us. And for us as an organization, in our residential treatment program, we had a really hard time getting above 30% American Indian Alaska Native into our residential treatment program until we were able to implement this carve out. And then we immediately jumped to 50% and then steadily stayed at 80% American Indian Alaska Native. On a local level, the city passed the first of its kind missing and murdered Indigenous women legislation, actually had real finances attached to it, and we're now getting a position placed within the police SPD to be able to address the data concerns and just overall the issues associated with our people going missing and murdered. We established a King County Missing and Murdered Indigenous Women Task Force. And for the very first time, there was a point where both Abigail and I were leading the King County ACH and also the Best Arts for Kids initiatives, which were the two largest funding streams coming into the city of Seattle, into King County at the same time. And it's interesting when you think about that, having two Native women in those leadership roles is pretty phenomenal. And then also we've been able to leverage some of the grassroots voices who really started this work, you know, and to lift them up and actually help them result into true policy change. So what I always say, this is how we've done it, as it's about building relationships. It's always recognizing that and respecting tribal sovereignty. It's staying spiritually grounded, sharing our practices, but without losing the integrity of the practice. It's about making systems work for us and taking the time to educate folks like we are today to get folks to become allies and partners. I actually like accomplices as the better term. I would like to have a whole state full of accomplices to help us realize, you know, our potential as Native people. I will say that these are some common misconceptions. I like to include these, especially when I'm giving presentations to non-Native folks, because we hear these things, right? We hear these ideas that all Indians are dead. You know, we hear that. Actually, we have one of our youth who was in class and introduced himself in his tribal way, and he said, "Oh, I didn't know that. I thought all Indians were dead," right? This is a kid who is 8 years old. So I want you to know these are things that occur on a daily basis and that we have to constantly address in order to create true policy and systems change, because we have to undo those wrong ways of knowing. And Indians don't live in cities. People say that all the time. They always think of us as just reservation people. College is free for all Indians. I'll have to tell you, the first time I did a presentation to our King County ACH, somebody asked me that question. And I thought to myself, oh my gosh, where am I? You know, but truth was I had to take a deep breath and, you know, just educate folks that no, in fact, I have student loans just like the rest of the world, and they consume a great portion of my income. And yeah, that's not the case. Although there are some tribes who have enough resources and have had the ability to pay for some college for some of their youth, and that's great. I want to see more of that occurring. All Indians are alcoholics. I mean, there are these ideas that we have issues with substance use, and some of those things are true, but people also don't understand that we also have the highest rates of abstinence of any other ethnicity, right? Of any ethnicity. And they don't tell that story. And so when I think about taking strengths in addition to disparities, we have to tell the full story. That all Indians get money from casinos, or that casinos don't pay their fair share of taxes. Those are all crazy misconceptions. You know, in order to even enter into casino agreements, they have to enter into compacts. Oftentimes, those compact agreements can be up to 38% of the profits from casinos. And so if you think about a corporate tax versus that 38%, corporate tax is roughly 8% tax, right? So yeah, I think a lot of casinos would like to be paid or like to be treated like corporations and pay only 8% versus 38% of their profits. You know, we hear it a lot. My great-great-grandmother was a Cherokee princess. My question about this concept is, why is it always a princess and never my grandfather was, my great-great-grandfather was a Cherokee prince? And that's because historically this idea of a Native man being with a white woman, you could just never fathom, right? But having a white man being with a Native woman was something that we could tolerate, right? And so that's why you always hear it from a princess perspective, and I challenge you to take a look when you hear it. Indians receive free healthcare. No, we're definitely desperate for resources. We're promised free healthcare, but that's not the way it looks. And I think that you have some ideas as to why now. So with that, I would just say akahe, and I'm open to any questions, and don't hold back. Thank you very much for having me.
Thank you so much. I feel like I just got about 2 hours worth of information in a really short time. But thank you. This is really pretty incredible. And thank you for allowing us to record it as well, because I know that we've got others who will want to be able to listen in and see this.
Absolutely. And I know it's a lot of information. I mean, I teach a whole class on this. So, I mean, we have 45 minutes to get her done.
Are there things that you wish the ACHs were paying more attention to, or looking for ways to partner on, or things that you see as opportunities that we should be paying attention to?
Yeah, you know, and this is something that we've been able to implement within our ACH, is we actually created an 8% carve out of resources for our tribal partners and also our urban programs, recognizing that we have a responsibility, right? If these funds are supposed to supplement this underfunded system, that we have to make sure that those resources get to the right place. So I would say that that's one thing. I would also say recognizing that you're dealing with tribal, like sovereign nations, and treating that with that level of respect. You know, that it's really unfamiliar and confusing to them as to why they would have to participate with the ACH at all. So really being patient and open, and just letting them know what type of resources are available. I think that's very, very important. I think that it's important that we hold positions for all of the tribes in the governing seats, because they deserve that, right? You wouldn't, yeah, it's just, that's the level of respect that you need. I think that also understanding that our cultural center is just as valuable as the data, right? And so we've been able to make some adjustments within our own ACH to really implement culturally attuned systems of care and be able to design. We've had freedom to design systems to capture the impact of traditional Indian medicine, right? Which are not the ways that the state is looking at it from a measures perspective. So, you know, thinking, I would say, like, even though the state has put a lot of restrictions on the way that we're to implement and distribute these funds, really holding true to the fact that they are innovations dollars, and putting culture at the center of those innovations. Those are things I wish all of the ACHs were doing, because what you will find is that your return on investment in Indian country is significant. I'm seeing some chats. Let me see if I can, let me open these up. So Tempest, if you want to read the chat, that's fine. I don't know how you want to do that, if there are questions in there.
Okay, Mike says, thanks so much for this presentation. I appreciate your outreach and work. Just a small point of clarification. Are all Indians who don't live on reservations considered urban Indians, even if they don't live in an urban area?
Oh, I see. You're talking about folks who live in rural areas. So the urban Indian designation is defined by the Indian Health Service and the service areas that they deem to be an urban, within the scope of the Urban Indian Health Program. I will tell you that loosely, people do not identify as urban Indians. It's something that in the healthcare world we've adopted because it's actually written into statute. That people identify as tribal people regardless of where they live. But the urban Indian designation is defined by the IHS service areas.
Are there any other questions for Esther? You can unmute yourself or you can chat your question in the chat box.
Esther, would you be willing, if questions come up later, for us to be able to reach out to you and just kind of gain some more insight if there are additional questions?
Sure, definitely. And then I would highly recommend following up with a tribal partner, right? So that you can gain that tribal specific sovereign nation perspective. Yes, absolutely. And Tempest knows how to get a hold of me. You guys just got lucky. I tried to hire her, but you got lucky.
We have been incredibly blessed, and and I appreciate your comments about the work with each of the tribes. We do have, our board does have a seat designated for each of the 8 tribes in the North Sound region, and this journey that we've been on has really been in concert with the tribes, and it's just been such an enriching experience, I think, for all of us to have partners building relationships with each of the tribes, for them to be seeing opportunities that, were probably always there, but that relationship building has just been an incredibly important piece to invest in. So, I think a lot of what you're describing, we are on the journey. So, but it's really just been amazing. And I appreciate hearing about Tempest and that other people want her, because I'm really feeling blessed that she chose to come and work at North Sound.
For sure. Yeah. Well, I will just say thank you so much. This is like definitely a passion point. And we're here. Please use our resources. So I would check out our Urban Indian Health Institute's web page. We actually have data dashboards there that can be really useful. All of our policy work is there. So if you want to read our policy briefs or our policy priorities, those are all there. Any of our learning tools, especially related to COVID, they're all on that website. And then please check out our website as well. And if you have any of your tribal communities who are out here, we're happy to share information about how we're caring for those folks. So I just want to say, I raise my hands to everybody. Thank you so much.
Thank you too.
Thank you for your time, Esther.
All right. So we'll go ahead and close this session, and more to come on our journey.
Thank you.
Take care.
Thanks.
Thank you.